esteemed group of consultants from the University of Pennsylvania, led by Ezekiel Emanuel, who's the creator or one of the architects of the Affordable Care Act, as well as Kevin Volpe, who's one of the leading experts on behavioral economics. They were our consultants for that. And then we convened every year a blue ribbon panel where we took about, I think it was about 15 national experts on healthcare, and we brought them down and we had them review the concepts we were drawing up and comment and kind of throw darts at it, so that we had input from local physicians, we had input from local pediatricians, we had input from national experts, and we had input specifically from consultants who do this.
And so all of these people said that we should continue to give the same report to the patient that they have always been given, and while the payment actually is totally different, that the doctors are receiving, through payment transformation. Is that what they all agreed upon also?
I'm not sure I understand your question.
So your EOBs that go out to the doctors, that go out to the patients, I remember asking this question to you 2 years ago, I believe, and you said that was perfectly fine for patients to be getting these explanation of benefits that say that, okay, physicians are charging this much, we are giving them this much, and this much is your copay and all that, that it would be the same explanation of benefits, and that it would be okay with Medicare. And we never got, physicians never got anything written from Medicare saying that it was going to be okay. Apparently it is okay because it's been going on, but I'm just questioning whether that was also part of what everyone in your group said, that it was going to be good for payment transformation.
The group probably didn't comment on benefit because benefit is different than design, but we do have a written statement from our regional director of CMS saying that that is correct. It is fine for us to show an EOB as it was and to have Medicare coordinate benefits as a secondary payer based off of that. Any other questions? One comment I did want to make that I think is a praise to all of you is I know when this all began, there was a lot of angst. There was a lot of unknowns. I mean, I will be perfectly frank and say not all of us knew exactly what we were doing, right? Let's be honest, right? CMS didn't know what it was doing. It's a brand new demonstration project. We at HMSA, we didn't know what we were doing with this because we're dealing with new partners and it's a new program. A lot of questions that you had, we didn't know the answers to. First of all, I would say it was a leap of faith for you to get in, and we thank you for that. But also, I wanted to say that first quarter reporting went with all the angst. It went without a hitch, and in fact, my understanding is Hawaii did terrific on their reporting. I mean, we pretty much had 100% compliance with reporting, and we did it at a very rapid pace. So we were we were exemplary across the country, and I think that's a tribute to all the providers, and I hope we continue doing well because I think there's a lot of good that can come out of this, as my earlier comments pointed out. Yes, there's a question.
Going to the EOB question, is that going to change in the future? I get probably no less than 5 or 10 phone calls a week from patients when they get their EOBs because it'll say depression screening not covered in your plan. And now they're calling us before they get their statements, but they're upset because their plan doesn't cover depression screening. We have to do pap smears, but there's still several HMSA plans that don't cover pap smears, but the patients get a full bill of $116 in this case because their plan didn't cover pap smear, but yet we're required to do it, but we're the ones getting yelled at for it, which we should do it for their benefit, but they're getting charged for it.
Your question about covered benefits is it's not unique to payment transformation. It would be true whether we were still in a fee-for-service claims-based system. If something is not covered, then the member is held fully responsible for it. So
but
unfortunately,
Sorry to interrupt you. In that scenario, we probably wouldn't do it, though, because we know it's not covered. We kind of give them the option. But with the payment transformation, it was kind of explained that it would be covered. And it's still an expectation for us to do to meet our quality reports.
My understanding is pap smears have always been on the quality measures before payment transformation or not. So I don't think that's changed. I think it's still a joint decision, a shared decision-making decision that you make with the patient and yourself. Any other questions? No, otherwise, I appreciate, again, mostly I appreciate all the PCPs who've been partnering with us, both in payment transformation for HMSA in our CPC Plus program. I mean, I think no one is going to, as our current president is once said, who knew that healthcare is so hard, right? It is hard. It's hard for everybody. It's hard for the people who are trying to make it a better system. It's hard for those of us in the front line who are trying to deliver care. But it's also a lofty goal, right? I mean, we're trying to make a healthier country, and there really isn't a better goal than that, and there really isn't a better mission than that. So just want to thank you all for being partners with us on that journey. Thanks.
Thank you, Dr. Mugiishi. And this is a partnership, right? Because CPC Plus is a multi-payer partnership. And so this is the first year of a 5-year program. And we talked about, I think in one of our first launches, we talked about pacing ourselves. And so as we move through the program, we will be pacing ourselves so we don't burn out and we can survive at the end of 5 years. But our payer partner collaborations, they will continue through the 5-year program. And so as things, I don't want to say change, but as things evolve and we make this program better, we want to make sure that all of you are connected and linked in. And so we really encourage you to stay connected, whether it's through CPC Plus Connect, whether it's through your PO, whether it's through, directly contacting me, or, there's so many support systems out there for you guys. And I think that's what makes Hawaii very unique across the different 14 states that are currently in CPC Plus, is that we do have a lot of resources. They are not unlimited resources. There still is a limitation to the resource, but we are here working together to support all of you in the work that you do for your patients and for our community, and we really thank you. Sometimes we get stuck in the weeds and we don't remember why we're doing this, and so we really thank you guys for being the part. You guys are the leading role in this Broadway show that we call CPC Plus. And so with that, I'm going to go ahead and give us another break so you guys can check your email and do what you need to do. And we're going to come back in this room. We will have our afternoon breakout session. So in the Pikake room, which is the room that you're sitting in, it's going to be fundamentals and transition of care. We're going to be looking at workflows, measuring progress, and using the Hawaii Health Information Exchange. In breakout B, which will not be recorded, is the care management, optimizing your day with pre-visit planning. And so we really encourage you to, if you have more than one person from your office, maybe you can share, and one person go to one section and the other person go to the other section. But if you're only one person from your practices here, we would love to have you here because we're going to have a lot of panelist discussions. In fact, there'll be panelist discussions in both sections. So we just ask that if you are attending that other session, we have the slide decks out on CPC Plus Connect. And this slide deck out is on CPC Plus Connect as well. But this session will be recorded. All right, thank you guys. Okay, can you guys hear me? Oh, I can hear me too. That's really loud. Okay, where's that clicker? Okay, so this is breakout session A. We're going to be talking about transition of care. And I want to bring up all of our panelists. Some of them are up here already, but there are two that are missing. So I want you guys to drive this session. The slide deck is really lengthy, and I put it in there kind of thinking it was better to have more than less, so that if you guys did want to talk about something, we could stay on that topic. But if you don't, then we can talk about what you really are wanting to ask and inquire about, especially since we have such a big panelist group. And so I want you guys to help me drive that discussion and interaction, the sharing and collaboration that's going to happen today. Oh, I hope I don't fall off the stage. Okay, so I'm going to introduce our panelists. From the HHIE, we have, obviously, we have Francis Chan. And let me read you his bio, since I asked him to send it to me. So Francis Chan is the Executive Director of the Hawaii Health Information Exchange. He has over 25 years experience in managing lab, pathology, financial, health, and medical information data exchange among hospitals, physicians, health plans, and public health agencies. He has guided the implementation of the HHIE Direct Secure Messaging, which we'll talk about today, to support transitions of care, as well as designing and implementing the HealthyNet Community Health Record. Again, we'll talk about that, which is a virtual chart of the patient's record that physicians and their staff can query. Under his supervision, the Hawaii HIE Community Health Record was born to support clinical quality reporting, leveraging technology to make data exchange available in near real time. So that is Francis, and he is also accompanied by Dr. Rebecca Burton. And so they're going to be talking about HHIE and how we can use them for transition of care. We also have Dr. Kohatsu, and he is from small practice. And so he'll be sharing his experience today with using the HHIE in transition of care. And then I'd like to bring up from our North Shore, Kohuku Medical Center, we have Annie and we have May, if they can come to the stage as well. Is May coming? Oh, okay. All right, we can back one of those chairs up. Okay, so now that we have everybody up on the stage, what do I do with that clicker? Oh, one more, okay. Okay, so for those of you who are live streaming or on the chat, they're all getting lays. So that's what we're doing right now. Session objectives. Defining episodic care management and the purpose of care coordination. We don't maybe not need to stay on that topic too long, but discussing care coordination between primary care and hospitals/emergency departments using the HHIE. Identifying the key elements of successful transitions, accessing the efficiency and effectiveness of your current process, and formulating a plan to implement or optimize one care coordination process. So this is really, if we tie it back to CPC Plus, this is driver number 4, not function. You know that within the comprehensive primary care function, there's 5 functions, but this is one of the drivers. So we're looking at optimal use of health IT and specifically data exchange. So I put this together, analyzing your Q1 reporting stats, and basically I just developed my own 3 categories. You were either not tracking patient follow-up from hospital and ED, you were doing some tracking or you were doing tracking all the time. And so based on what was reported through Q1, you can see why this session kind of resonated. When I thought about what sessions we could talk about, this kind of came front and center, as 40% of really have a good way to track hospital discharges within 2 days and then ED discharges within 7 days. And now that we're in a reporting period, you're gonna get that same question if you haven't reported or if you did report. And so just kind of trying to look at ways to track that. The other thing that was included in that care delivery report was interoperability, whether you or not you were using, some technology, so an HIE, or did you have access to a hospital EHR or portal access? And so about 25% of you said yes, you are actively using the HIE to help manage transition of care, or at least exchange data. And then for the access to hospital EHR or EMR, 71% of you said yes, you did have some type of access, whether it was Care Everywhere or doing CCDA interop exchange. So just trying to look at the data, we're going to be focusing not so much on the access of the EHR, but really the using HHIE. So questions to consider as we kind of jump through this session. How efficient and effective is your process for gathering and acting on transitions? How can you improve your process and patient engagement for episodic care management? And then do you differentiate between episodic and longitudinal care management? And if so, how? And so that's kind of an interesting question, because I think within each practice, you guys might do it a little bit differently. So I don't want to spend too much time, but there is a section for episodic care management in the change package. If you haven't gotten through that yet, you definitely want to take a look at it. And that's on CPC Plus Connect. So just kind of, episodic care management, it's the short-term goal-directed care for your patients whom your practice has not already targeted for longitudinal care. So that's kind of the patients that we're talking about. And the focus is around care management activities that can resonate through an acute care event or episode. So episodic care management can come like we said, transition from hospital or from the emergency department or urgent care. It can also be a new diagnosis or an injury, or something's going on in one of the chronic conditions that your patient has. Coordination is an evolving process, and I think with technology, we're trying to find ways to do it more efficiently and more effectively, and that's really where we're going to go with this learning session, is how to do that more effectively. So I'm going to just kind of jump through these slides. Does anybody want to talk about the role of the care coordinator? You guys okay with that? Okay. Who are our neighbors? Just kind of as a PCP, there's a lot of different places that you're touching, and so and that touch you back. So we want to start looking at who are our neighbors, and that's where we get into the HHIE as one of the neighbors that is in this community. So I'm going to turn it over to Francis.
Good afternoon, everybody. Thank you, Christine, for inviting HHIE to join this discussion. Many of you are probably somewhat familiar with HHIE. Can I have a quick show of hand, how many of you are familiar with HHIE or using the solutions? It's quite a few, so thank you. What I want to point out, a little bit of an infomercial first, right? So what is HHIE's mission? Our mission is to positively transform healthcare in the state of Hawaii through efficient exchange of critical health information, health and care information. And our commitment is that HHIE is a neutral entity, so we don't take sides, so to speak. I mean, we try to be neutral. We make sure everybody in the community who delivers healthcare and care for patients can effectively use our technology, which we try to be innovative, and then we delivers essential health information to providers, and then we hope that the providers are able to use the data to improve the quality of care and improve the outcome of the patients. And of course, we see information sharing as a shared responsibility. And HHIE work with the hospital, with providers to make sure that everybody is able to share information effectively. And so it's now most of the physician and the staff here in this room probably are the ones who are accessing the community health record to support their treatment activities. But we would want to have most of you who, if the EHR can support that, and since you're in the CPC Plus program, I'm sure you have the EHR that can support that activity. We would like for you to share the patient data with the specialists, with hospital, with ED physicians. So how are we connecting our neighbors? So right now we have HHIE, what we collectively call the Healthy Net Solutions. So the Healthy Net Solutions have the community health record, which there are several features in the community health record that as a CPC Plus participant you can leverage. There is a results inbox. You can use that actually as an in-app solution alert. When you have patient discharged from the hospitals, we can set it up so that you can receive a notification. Now this is the first step, like Christine mentioned, that we want to be able to send like an alert to your smartphone, your device, your email, that you want to know that, okay, you have an alert, so you can just log in and check for the record. But right now you have to be in the record to see that there is an alert. And inside the portal, there's also like patient encounter information. Whether the patient went to the ED because of a car accident, because of like an episode of like sore throat, or whatever the reason may be. I mean, hopefully sore throat they didn't go to ED, but if there are any encounter that they went to the hospital or the ED, there will be a record in the CHR so that you can see and find out like what the problem was, why the patient was admitted, or why the visit, what the reason behind the visit was. And then there are a lot of results. So when I say results, it includes, of course, laboratory results, but there are also results from like, radiology studies, consult reports if the patient has surgery or a procedure. So all those results are available in the community health record. And of course, I think one thing that I think a lot of providers who find useful when they interact with high complexity patients, of course, if it's a pretty normal patient, the medication is pretty straightforward. But when the patient is taking 10, 15, 20 meds, then it's hard to get all the information together. But the HHIE Community Health Record provides the all-in-one summary that you can access the medication history on the patients. And those are the medications that the patient have picked up in the last 12 months, not the one prescribed, so that you can also easily, if you know that there are scripts that the patient, that you have given to the patient didn't pick up, then explains perhaps why some of the complication you are seeing. And then, of course, we have different way of accessing information in the community health record. For example, with Hawaii Pacific Health, they use a strict query, real-time query approach, so that you can just, bring up the patient, get the patient into focus, and then submit a query, and within a few seconds, the results will come back. and that it comes back as a consolidated CDA document or CCDA document. Most of you are familiar with that you can download or you can just read and then, or just, okay, I'm satisfied with the information, I don't need to keep it, and it will just, then you don't have to do anything more with that. The other module that we have in the HHIE is the referrals module. Now, unfortunately, at this time, the referral module does not integrate completely with any EHR, but yet it serves the purpose of providing end-to-end referral management between providers. So whether you're a PCP or whether you're, or you have your partners specialist that you want to communicate with, you can use the referral module to initiate a referral. And if a specialist wants to set preferences, for example, the receiving provider wants to have all the pertinent lab results attached to the referral before he or she will accept the patient, or make sure that the sending physician or the office knows that certain procedure can only be done on certain days, then all that can be stated, and then the sending provider doesn't have to go and chase after all the information after the fact, and then potentially delaying the patient's receiving the treatment that he or she needs to take care of the problems. And also, I think what we find nice is that the referral platform allows both the PCP and the specialist to track the status of the referral. So whether the patient has been scheduled, and if the patient did not respond to the scheduling call from the specialist, that can be communicated. If the patient was called 3 or 4 times and did not respond, then the receiving provider decide to cancel the referral, then there's no question. You can see that in the platform. And also the sending and the receiving providers can actually communicate through SMSs, like your smartphone. You can send a message, you can attach a document, a picture, or even a recording if you want, like a short recording that you can send through the referral platform. So there are some nice features that allows you to manage the referral. Only catch is that you have to also enter that into your EHR so that you can accurately count all the referrals that you have sent and received. The other module is the direct secure messaging. Most of you are probably familiar with that. And the HHIE direct secure messaging is Direct Trust certified, and we can use that to support transition of care and the CC exchanges. And the nice thing is that it does not matter. I mean, if you did not subscribe to the direct secure messaging on your EHR and you choose the HHIE version, we will allow you to communicate with any other EHR who are also on Direct Trust, and there are quite a few of them. Now, some providers choose to do that because, typically, I think the EHR charge a little bit extra for the direct secure messaging, whereas if you are subscribing to the HHIE, we did not charge extra. It's all a whole package that you can use all the features and functionalities that we provide on the direct secure messaging. And if you need to attach a document, you can attach up to 20 megabytes, which is more than most email can support. So those are the nice things that we offer with the direct secure messaging. Any questions or comments at this point? Okay. Moving on, just to give you an idea what data are available. So we have almost all the hospitals. And the next slide, I would indicate, I will show you who we are not connected to. But this chart shows you all the hospitals who are connected across the state. And we get the kind of information that we get from the different hospitals. Not all hospitals are sharing everything, but I think there's enough information for you to make good use of the community health record. And the hospital with whose data are not being shared with through HHIE as of July, this month, Tripler Army Medical Center, we don't have anything, any connection with them. Kaiser Permanente of Hawaii, we can communicate with them through direct secure messaging. The Maui Health System, which is like a Maui Memorial Medical Center that went to the Kaiser system starting July 1st. We used to have connection when they were part of the HHSC environment, but when they switched to the new new partnership with Kaiser, we do not have that connection, and we will be building that. But meanwhile, we can still connect with them through direct secure messaging. Now, Kuakini Medical Center, it is a very interesting story because most of you know that we are working with HMSA to deliver the hospital ADT or the visit history, like discharge or admission records, to the COREO system. And because they initially wanted to start it up like by June 1st, so we said, okay, we'll support that first rather than have it go into the community health record, which takes a little longer. And so we have the ADT from Kuakini going to the COREO, but not to the HHIE system yet. And so perhaps like in the next few months, we'll get that going, and then the data in the community health record will be richer. Now, again, for Kahuku Hospital and Wahiawa General Hospital, we are working with them to connect and share data, but regardless, we are already able to communicate with them through direct secure messaging. Any questions or comments? So you may want to know how many ambulatory physicians are actually sharing data at this point. So we did a little count, and then approximately 450 physicians are sharing data. So meaning that in the community health record, you not only get the hospital data, you also get the ambulatory data for those physicians. So who are those? They are the HPH employed physicians, like at Straub, at Kauai Medical Clinic, and then the Queens employed physicians, and the Queens Connect physician using the EPIC system. And then also the clinics affiliated with Hilo Medical Center, they are also sharing data. And we are actively working on connection with federally qualified health centers. Those mostly are the Medicaid patients, but if you're part of CPC Plus, it doesn't matter whether it's Medicare or Medicaid patient, you have to follow the best practices. So if you have a patient that also goes to one of those community clinics, once we get those connections, you'll be also able to get the data from them. And of course, we are continuing to onboard more independent physician practices. So we are working with HPH, EPIC, for what they call the Health Advantage Connect doctors. And then Elation EHR, and some of you already are using that. We are working with them to get data. eClinical Works, that's the other one. East Hawaii IPA has chosen ECW as their preferred EHR system, so we are working with them to support the East Hawaii IPA physicians. And of course, GE Centricity, which is very popular, we are also trying to work with them to get connected. So a little bit of a statistic just to show the usage.
We can skip that part only to get for the element,
Okay.
yeah, just for the
Okay.
sake of time, but kind of get, maybe one more.
Okay, maybe. Okay.
Yeah, right here.
Okay,
Yeah.
sure.
Okay.
Thank you.
Sorry, I don't mean to. I just want to make sure that we can get into actual usage and how a physician practice is using the data, and I think that's what you guys want to kind of hear. Is that okay? Or okay, all right. So I'm going to skip through this coordination and get right into Dr. Kohatsu. Thank you very much, Dr. Kohatsu, for joining us as a panelist. If you can just tell us a little bit about your practice, and then we can go into the next slide. Is it on?
Hello, can you hear me?
Yes, yes.
So thank you very much for having me up here. And I do want to emphasize that for our practice, this is a journey, and I will not claim that we have this perfect, and it is a work in progress that we're continuing to refine. But for those of you that don't know me, I am part of a small group practice, 2 physicians. We have a total of 5 staff. That's 2 health managers. The best we can describe it is it's a hybrid medical assistant and care manager position. So we have 2 for each physician, and we do have 1 shared office manager / biller.
Okay. So basically what we wanted to talk about is your transition of care and what you're doing and how you're tracking that. So which hospital EDs do most of your patients commonly use? Like, where are they coming from?
If you don't mind, I'll digress briefly
Yes,
just to give a
of
little bit
course.
of background. So just to give you a little bit of timeline in this process, when I first started practice and we first started tracking transitions in the care, the term I'll use, it was very reactive. So we tried our best to schedule patients after a visit, after a hospitalization, but we definitely did not have a method to track or to get data on how we're doing with follow-up. So that was the beginning stages of this. I would share one major marker was around the time of 2013 when the Transitional Care Management Code came out. I actually have to credit my wife, who was in the office at the time, and she really spearheaded trying to get our workflows down in order to meet the criteria for transitional care management codes, in order for our office to be able to be paid for the work we're already doing, and I'm sure all of you are doing in caring for our patients after the ED or after the hospital. So I would say that was a marker where we did start the processes of trying to set up a formal follow-up protocol in order to meet those criteria. But the major difference at that time, we still did not really have a refined tracking system in order to get our data down of who was in the hospital, who was, how are we doing with follow-ups? Could we be doing a better job? Those were all some unanswered questions at that time. Another huge milestone, which all of you have joined with us on this, is the CPC Plus program, and I think it's been a nice step to partly forced, but also I think in order to improve the care we give to our patients, it has allowed us to further refine our transitional care management for these encounters after an ER or hospitalization. And I think through the requirements for CPC Plus, now we've slowly developed some workflows and flow sheets in order to track them and actually start using that data. And I think in a few slides there'll be an example of this.
So talk about your current process of how you're tracking it and what you're using to track.
So currently, so we do depend on a triggering event. So that is some type of notification that one of our patients was in the ED or in the hospital. This can be a combination of several different areas. First and foremost, another marker was we did transition to Queen's Epic about 6 or 7 months ago. So there is an electronic alert that we do receive within our EHR that there was some type of event within the hospital. The second type of alert we get is still through fax. Although we do receive electronic faxes, we do get fax documents from certain institutions when a patient was seen in a facility.
What institutions are those that you get them regularly that are pretty top?
So I would say the ones that we get that fax regularly from are the HPH facilities.
Okay.
So I would say that does happen regularly.
Okay.
The last, or another area we get alerts from are from patients or caregivers. We do try to foster an understanding among our patient panel that we be alerted as their primary care physician when there's any major significant change.
Do they do that through the portal? How do they alert you?
So a combination. It would be through the portal, a phone call. Some people even stop by. If the person's admitted at Queens, we have had patients or caregivers stop by the office just to let us know what's going on.
Wow.
The last way we're being notified is actually something neat and in development, and as part of this talk of being on this panel, we've been able to collaborate with our colleagues at HHIE, and we're trying to refine our alert system within HHIE. just about 3 weeks ago, we were not getting alerts from institutions like Castle, and it was very news to me that that was a possibility. So thankfully, from the help of our colleagues, this supposedly has been worked out, and it just happens that we haven't had any admissions to Castle or HPH as well. So we haven't had a chance to test this workflow, but we are hopeful that this is something in the future we can utilize.
So let's talk about like 3 weeks ago when the four of us were kind of collaborating together as we were preparing for this session. One of the things that you had said to me, actually, he reached out to me and said, you know, we're not getting any notifications from this one hospital. And I go, oh, it's on there. You should be getting it. And so what happened was I connected Francis up with Dr. Kohatsu, and they had a conversation. And can you share with the group what seemed to resonate from that conversation?
Yeah, I mean, for me, admittedly, we were an early adopter, I would say, of HHIE when they were coming out to Queens Connect providers or the Queens CIPN providers. And at that time, there was a lot of things in development. And I believe at that time, the ADT alerts were still in development. And after some time passed, I sort of just lost interest in that area. And I had forgotten that that was a possibility. So by having this group meeting that other week, it was actually very neat to be able to learn about the capabilities that have transpired since then. And I've definitely appreciated the collaboration among our colleagues here. And I'm hopeful that this will be an efficient way to get alerts rather than waiting for that phone call or fax.
What's been one thing that you have been able to adopt into your process now by using the HHIE?
So slowly, we are working with our health managers to also incorporate HHIE into their workflow. So that is another database they are checking in order to capture some of the data from our other neighboring institutions that are not Queens-based, where we get it directly through our EHR.
Okay. I don't want to ask all the questions. Do any of you guys have any questions for Dr. Kohatsu as you kind of see his process for managing and tracking discharges from the hospital and ED is still evolving, and I think it will continue to evolve. Anybody have any questions that they'd like to ask Dr. Kohatsu or even HHIE? Okay. Yes.
What is the timeliness of those feeds for, say, hospitalization or ED, since we are on a timeline to contact those patients? What are you seeing in terms of the time to actually get that information from HHIE or via your other systems?
It's a real-time data feed, ADT data feed, and it goes into a results inbox. And you just sign into the HealthyNet, and you'll see a number above that results inbox, and it'll alert you that you have either admissions or discharges in the hospital or from the emergency room. So that part is real time.
So from a workflow perspective, it's basically either assigning someone or having a dedicated person at maybe a certain time of day that's going to go into that inbox and check to see if there's any notifications that were pushed to the inbox because a patient selected you as the PCP. Any other questions? Yes. Is there still a fee?
There is an annual subscription fee. We're charging $600 a year for use of all the features that I've described earlier.
Okay. Yes.
We started charging this first year in January, and it was per provider, but we are going to revise that so that it is a user-based subscription per practice, which is in effect lowering the subscriptions because we do want the community to use the tools, and so we understand the fee potentially is an obstacle, so we are lowering that.
Yes.
I'm confused about the connection between Queens Connect and HHIE. Are those coming through as staff messages now, or is it still two separate programs?
So it is two separate programs. So Queens Connect is our main EHR. We had transitioned over from another EHR about 7 or 8 months ago. So there are two databases that we are managing. I'll be honest, I think one of the questions on that slide was where are the majority of our ED and hospital visits coming from? For the most part, most of our visits are coming from Queens or from a HPH facility. So the notifications are there, and there are processes, even irrespective of logging into HHIE. But admittedly, through this data tracking and analysis, we were able to identify some of our problem areas. And these are, unfortunately, some of our smaller community hospitals that I think HHIE would be very helpful to us. One example I gave to the team up here was we did have a patient admitted to a smaller community hospital, and it was unfortunately about 3 months later that we were notified about a sentinel event. And thankfully nothing had happened with this person, but I mean, I'm sure you all can imagine what can happen in 3 months. So it's our hope that by refining this process further, we can capture and fine tune even further our hospital and ER follow-up.
Right. And I think even just talking collectively, you know, we call it the little pilot project because, you know, HHIE rolled out this tool, and, you know, now the question is how usable is it? And so that's where we're, you know, looking for, you know, practices to join this collaboration to figure out what the usability is like so that they can either fine-tune how their system is working or address issues that previously they may not have known about. And I think some of the issues were a setting issue. You know, how is your feature set up in your system to receive that information? And if you don't turn on certain functionality, you're not going to get that information. So some of it was almost, you know, I don't want to say re-education, but learning how to use the system and navigating the features of the system.
If I can just also add, although we haven't been able to test the ADT alert system, my staff has appreciated access to one of the smaller hospitals in getting discharge summaries. So that was something we struggled with in the past in order to get information about what transpired in the hospitalization. And this has definitely made things a lot easier. And they were able to get it for me in real time while the patient's in our office.
Mm-hmm. Right. You know, I will say that for the HHIE, I mean, you know, we heard about the timing being an issue, and in order to, you know, charge for a TCM, you know, you have to meet that 2-day, that 7-day follow-up. And so this is where the HHIE can help you manage that process. But there's still the other piece of that process, or the other side of that coin, which is documenting and tracking. And so I do want to move into that if there are no other questions for Dr. Kohatsu about how he's using the HHIE or what other benefits he's seen in the last 3 weeks as we are kind of piloting down this road of trying to improve notifications. Okay. So there, with the care delivery reporting, especially since we're in a reporting session or we just completed one, you guys are very well aware of the question about, do you track your ED discharges and your inpatient discharges? And so they're asking for a number. And for many of us early on, it was, okay, we do it, but we don't have a way to track it. So Dr. Kohatsu, can you share with us what you're doing to track that information?
So maybe it'll be helpful if I also share about the process that we do of what happens. So I'll just take it a step back and talk about when we get that alert that one of our patients was in the ED or in the hospital. We get that notification, and one of my health managers is charged with, number one, updating that list. So up on the screen, I apologize, it's in very small print, but this is a form that my health managers had devised, and basically this is helping us to capture and document the data that we need for the quarterly reporting. But in addition to fulfilling the requirements for CPC Plus in the reporting, this has been a very powerful tool that now we have been able to quantify which EDs, which hospitals our patients are using, as well as being able to see how we're doing with follow-up. That was always an unknown, but this form, basically we capture data of where the who the patient is, where they were seen, were they admitted, was this only an ER visit, were they followed up on, did we get a discharge summary? So these are some of the key data points that our staff are tracking for us, and they also do document a note within the EHR that they followed up with the patient. Was this within that 2-day time frame for a hospital discharge? Was this within 7 days after an ED visit? So that is also a separate documentation note that's going in the EHR. At that point, they send me an alert, so I get notified about the patient, the status, what happened, and from there we sort of coordinate and decide upon whether or not this patient will be followed up with in the office. More often than not, an office visit is scheduled to follow up on these events, and at that point, we see them for an office visit, and after the office visit, that's where the episodic care management comes in.
Yes.
Where on a case-by-case basis, admittedly it is falling on the provider's shoulders or my shoulders, that we decide who will be recommended episodic care management, where I charge the health manager with certain topics to follow up on, be it were they contacted by home health care, how are their blood pressures doing, are they taking their medications correctly. Basically, I give the health manager a targeted set of questions to follow up with the patient in 2 days, in a week. And basically, we have this back and forth dialogue over the course of the next several weeks or month until we agree upon that this patient has been stabilized and can be discharged.
Any questions about that process or about tracking in general? Yes. So the question is, how much time does this take?
So if I had to put an estimate on time, if you take the whole entire process of the health manager trying to look at databases, reviewing if we got any telephone calls, making this call, trying to coordinate discharge, I might estimate 1 hour. That's just rough guesstimate. On a good news, I mean, thankfully, day to day, we're not dealing with too many ER or hospital visits. But there are peaks, there are valleys, but for the most part, I would estimate on average about an hour. We also do incorporate hospital and ER discussion as part of our daily huddle. So we probably spend about 5 minutes just reviewing our list of who's in the hospital, who's been in the ER, have people been followed up on. So that is part of our daily workflow as well.
Any other questions? How many ED visits do you think you average a week? Do you know that? Or is a month a better time frame?
That's a good question. Admittedly, I don't know if
Okay,
know
sorry.
the answer offhand. If I had to estimate in a month, maybe 5 to 10.
Okay. And hospitalizations?
Rough guess, about similar, maybe
Okay.
closer to 5.
Okay. So as you think about your own practice and how that workflow would look like for you guys, do you guys have any questions about the workflow itself? No? Does anybody want to share their own workflow, maybe how you guys are doing it? Because, of course, there are many different ways to do this. Does anybody else want to share how they're managing transitions of care, or at least follow-up within for ED visits and for hospitalizations? No? Yes. Yes.
Just as a good action step, making that assessment.
Okay, so part of it depends on like where are your, like Christine mentioned, where are your patients being seen, if it has to do with hospitals, and how often do you refer a patient to a specialist, and how many of your patients are highly complex patients. Because what we have found based on our experience is that the patients who are higher complexity tend to have more information that will be useful to the PCP in the community health record. So I think those are the starting points that you would consider.
Right.
Yeah.
And now
Rebecca,
that you know who's in and who's out, you know, kind of who's in the system, like what information you can get in the system, I would say that right now, if a lot of your patients, like when you analyze where are most of your discharges coming from, if you said it was Wahiwa General or Kuakini Medical Center, right now the HHIE would not be a good solution for you because that data feed is not coming in. So understanding whose information is flowing into the HHIE is really important, and that's why, you know, we wanted to spend some time on this slide because that gives you an understanding of what information you can expect in the HHIE through the notification sitting in your inbox. And that's one of the things that we'll be testing with Dr. Kohatsu as more patients, more of his patients are being discharged from different facilities to see if indeed it is working and indeed it is real time and it's adding efficiency and automation to his existing process. Of course.
It's important for those that have HealthyNet subscriptions. That's the name of our product. If they do want those admission and discharge notices in that results inbox, to make sure that their settings are set up appropriately. And if so, just give me a call and we can make sure that it's set up if they're going to use the system. Okay.
Yeah, and in fact, maybe Dr. Kohatsu, you can kind of talk about that, how important the settings were, because early on, I think that was a big part of the information.
For myself, I think a lot of what happened for us with HHIE was just some assumptions and not asking the right questions. And thankfully, because of this panel group, it gave me a forum to ask some questions, and I was able to learn that HHIE had some more capabilities than I initially thought. And by working with our colleagues here, we're able to fine-tune my settings. And it's unfortunate, well, I guess it's a good thing that patients have not needed to go to the hospital or ER, but we're waiting to test out the new workflows that to make sure the alerts are coming through.
Yes, and as we test those out, we'll be sharing those with you on Connect, on CPC Plus Connect in the Hawaii Regional Network Group. Also, the contact information for HHIE will be out there too if you don't know how to contact them. If you already are a user of HHIE and you haven't been using it lately, kind of like Dr. Kohatsu, we encourage you to connect back up with them to make sure that your settings are correct and that you can get the information in real time.
If I can just add one more plug for tracking.
Yes.
So just one more story to share about tracking and its utility. So it is relatively new to us, I would say this year, that we're really making an effort to do this tracking. And I think, you know, unfortunately there are some areas on the island that are more challenging to be able to track information, but through this tracking mechanism, we're able to at least identify the problems and then hopefully come up with solutions on how to better track our patients. So it does entail more efforts on my staff behalf, but for some institutions, they've been calling the nursing floor every couple days, maybe once a week, to get an update on the patient so we don't miss that discharge.
Yes.
That's a good question. I guess to restate it for those of you that didn't hear, it was a question of whether or not this documentation template was adequate versus a duplicate note in the EHR. I think we toyed with that idea, whether or not to just leave it on this tracking board. I'll be honest, in an ideal world, if our EHR could do all of this for us, including to crunch our numbers, I would love that. for the developers in the room. But for now, I think we felt on a patient level, it's still important to document more clinical information in the note that might come up. So I have asked my staff to document the note in addition to the quick trackboard.
Would you say that that documentation in the EHR really helps you manage the episodic care piece more efficiently?
So I would definitely say so. It's nice to have an ongoing dialogue of what's going on from the time of just after discharge, that first phone call encounter, and the subsequent visits or touches that the health manager has.
I mean, your EHR might be able to produce a report, you know, if you're documenting it in a certain place within your EHR, if you're documenting it in a note that can grab and pull that out and do a count for you, that would probably be the best solution because it's a single source. But in this case, what he's saying is there's a limitation in the EHR where he cannot extract that information out to produce a report at this time. And so until that until his EHR can do it, this is kind of a temporary solution. Okay, any other questions? Yes, of course.
So just to let everybody know, if I think there are a few points that you can get as bonus point if you use the HIE, and HHIE does have the capability if you are a user to just send you a confirmation that yes, we do have record of your usage, and so that you can also use that as a supplemental documentation. If you need to have those few bonus points to help you get off get over the bar, right?
And maybe what we can do, Francis, if you could send me like a sample and then I can post it on CPC Plus Connect so people can get a visual of maybe what that looks like and how they might use that information.
Yeah, that's a good idea.
Yeah, maybe we can do that because I think conceptually we go, yeah, but when we can look at something, maybe we can figure out how that we can pull that into our workflow. Okay. Well, thank you very much to Dr. Kohatsu and to HHIE. We really appreciate your honest feedback and the information that you've provided. I thank you guys for your questions. I'm going to move into the second panelist, and this is Annie. She is the medical assistant for Kahuku Medical Center. And what we're going to be talking about today is what they worked on for their PDSA. And so, Annie, can you tell us a little bit about the clinic?
So our practice is a fairly small one as well. We are located in Kahuku on the North Shore. We currently have 2 physicians and a full-time staff of 5. Much like many of you, we've identified our ED visit and inpatient follow-ups as an area needing improvement. So we chose to focus on that. And much like Dr. Kohatsu's office, until just recently, had no workflow for it. And so we are now connected with HHIE, which has been a very useful tool in helping us track those patients. We also have, since we're with Cerner, we have a generated, so we do a daily generation of a list of patients that we're seeing in our own ED to follow up with. And that's been very useful in helping us capture those patients needing ED visit and inpatient discharge follow-ups. And just like Dr. Kohatsu's office, we do use the same tracking system where we extract information from either HHIE or from our EMR, and we'll manually put it into a spreadsheet, which we'll use to follow up with patients and track them that way.
So for some of you who might be thinking you want to evaluate your own process for how you're getting information for patients that are discharged from the ED and patients that are discharged from the inpatient setting, here's a PDSA or a sample PDSA that you can kind of take on and make it your own. In the other session, we talked about, changing the name of PDSA because it's maybe not a terminology that you use a lot. And so if we want to come up with our own name, I'm totally game with that. But for now, we'll call it PDSA. And so, what Kahuku did when they first ventured down this road to figure out, okay, how are we doing? Because that's really the question isn't, how do we get a number to put in the care delivery report? I mean, that's just one of the side effects. The real question is, how are we really doing managing the information, the notifications, and the follow-up with our patients when they are discharged from the inpatient and the ED setting? And so what they did is they kind of wanted to test the accuracy and the timeliness of the follow-up activity for ED visits, and they did it over a period of, I think it was a month, right? You guys extended it over a month because 2 weeks wasn't long enough. But I think the point here is to put a time frame on it. You want to evaluate for a period of time. And then what they did was they figured out what information they would need, and then they looked at what their initial thoughts were about their process, and then they took action. And I really want Annie to talk about the action that they took. This was really interesting for me as, just kind of watching from a distance, and I thought, wow, that's really great that they were able to start looking at using technology to automate instead of, sometimes we implement technology. You've implemented an EHR, and you become a slave to that EHR. And we want to get to the point where that EHR is working for us, not we are working for them. That EHR is working for us, and it's fitting into our workflow. And so did you want to talk about your results and then kind of what you did with that?
So because we're with Cerner, we currently don't share data within the HHIE. So what we found was helpful. We found a way within our EMR to generate a list of patients that were seen in our own ED, and it was very helpful in helping us, follow up with those patients. So now we are able to capture most, if not all, of our patients that were seen in the ED and discharged from hospital.
Right. So what this is showing here, the results, when you take a look at your PDSA, you can't work on everything. You can't begin to work with every single hospital out there that your patient has been discharged from. So the goal really is to figure out how you can get the most bang for the buck of the time and the resources that you do have. And so this data allowed them to focus on 57% of all of their discharges, which happened to come from KMC, and they were on the same EMR system. And so that's what this information is telling them. And they wouldn't have known that, what the percentages were, what it looked like, if they didn't do some kind of analysis. And so that's kind of where we are with this is, when you make decisions, you want them to be as informed as you can using data. And so that's one of the takeaways from them is that they were able to realize that most of their discharges are coming from KMC. So this is the action plan that they took based on that information. So did you want to share that? The detailed? Oh, can you see? Like this. Sorry. We all get node, we can't see too far.
So we kind of use the PDSA as a tool, and we didn't necessarily use it in this order, but we did create reports within our EHR to obtain a list of patients that were seen in our ED. Um, and that meant working closely with our IT department. Um, and this was done on a daily basis. So someone, either myself or another staff would generate that list daily, transfer it to the spreadsheet, and have a follow-up call made. And it was always within that time frame of 2 days following an inpatient discharge, or 7 days after ED visit.
Right. So in that third area, what they did was they reached out to Cerner, their EHR vendor, and they are working on a process to automate the notification between the two systems. And so what that does is it cuts down on the amount of manual labor that you have to do to track, to record, to document information. And so now that process is more seamless. And so that's where, you know, the PDSA, this particular PDSA, they had no idea that that was going to be the end result, but over the course of that month, based on the work that they did, and it didn't take, you know, years and years of analysis, they basically started off with 2 weeks, and then they expanded it to a month because they didn't have maybe enough data at that time being captured. And so, you know, it can, you know, the PDSA tool, it can be very useful as you try to evaluate where you want to put your effort and what action you can take now that you've done an analysis. Does anybody have any questions for Annie about just kind of her own process, what they did, how they did it, why they did it? Has anybody else done some process work improvement in transition of care or in tracking? Because I know we have 2 quarter reports under our belt now, and we all know that this is gonna be in the next quarter. So have any of you guys started to track this information that you wanna share what you're doing? Please? Yes, Dr. Belcher.
I, like the other people from the outer islands, have one hospital we deal with. And so the IPA made an agreement with the hospital. We're on Meditech rather than Cerna. And so quarterly, they actually print out a list of all my patients that have been in the hospital, track them that way. Since I'm on the staff, daily I go in and look at who's in the hospital, who's in the ER. The hospital's very interested in not having people bounce back, and so their case managers always make sure that they have an appointment with me when they're discharged. That's in the EHR. So I know when that is, and I have my staff double check that.
Right.
That's how we've been doing it out in the Hilo area.
So what list are you using to track, like when you had to fill out your care delivery report, how did you get that information?
It was delivered to me through the, from the IPA, a list of my patients that had been in either Hilo or Pahala Hospital in the prior quarter.
Okay.
The first time I did it, I just assumed it was the ones impaneled for CPC Plus, so it was a very small number. I've been told it was supposed to be everybody, so it's a much bigger number for the second quarter.
Correct. Okay, thank you. Anybody else want to share what they're doing, how they're tracking the information? I'm going to know if you guys put numbers in there. I'm going to see your data. Barry, can I pick on you? How do you guys track it? Sorry, if, James, if you want to give him the mic, sorry. I want everybody else to hear.
So I work for Hawaii Pacific Health, and for our care delivery reporting, we have focused on the discharges from other Hawaii Pacific Health facilities, so EDs and hospitals. And that's really our initial focus, is on the level of follow-up that we have, and to be honest, we have room for improvement on our own facilities. And I think the second tier of improvement is then improving the ADT info that we get from non-HPH facilities and then tracking better and doing better on the follow-up from those. So we're sort of approaching it in two different ways.
Right.
Like I said, we have room for improvement even on our own facilities where we have perfect information. Just the timely follow-up is the challenge that's most immediate. And we're pulling that information from Epic.
So how are you doing the like HPH type of discharges? Like, what are you using to gather that information?
We actually selected the box where we don't gather that information. Which I don't know if is completely true, but it's, you have to prioritize the data that you focus on for reporting, and that's where we are right now.
No, yeah, you've got to be strategic and intentional.
That's probably
you.
not the answer you were looking for.
No, this is a recorded event. No, I'm
We
just kidding.
have we have that data, but it is a bit tricky figuring out
Right.
matching it to the time frames exactly and validating it. And when we have all the available data for our own facilities, like I said, we've been intentional about focusing on those.
Right, right. And I kind of want to go back to this slide, and the reason why is, it's not a wrong answer, and I think, we all realize we can't do 100% of all of the discharges and all, for the inpatient and the ED setting, and I think to get started, if that was the goal, it's so overwhelming that you go, you know what, maybe I'll pick another topic. And this is such an important topic for episodic care management. And so, to only highlight where majority of your patients are being discharged from, that is probably, if there's any takeaway from this session, it's that. Where are most of your patients getting discharged from? Focus on that first and see what that process looks like. Anybody else want to share? Maybe another sole practitioner, because we've heard from Big Island, who has one hospital, and they're kind of working towards a solution, because in that setting, the demographics make a big difference by only having that one hospital. We heard from HPH, who's a clinic setting. I'd really love to hear from, yes, Dr. Kushima. Yes, retrospective is good.
ED and hospitalization. So when we were filling out the form for our Q2 reporting, so we noticed that we had to do this thing about ED and hospital follow-up. I knew that we had to do them, but this is how we did it. So one is that we have Epic, so we asked Epic, the people at Epic, to run our reports and the number of people that were, who the people were that went to the ED and the hospital. And what we did was they had the dates, and so what we did was look back and see if we saw those patients, on what day we saw them, and whether they were in the period or not in the period of time. And then for our other patients that were non-Queens and HPH, what we did was we have all those things, of course, sent to us by fax, and we have them put in folders of patients, charts, like you would in a regular paper chart, but except they're electronically. And we searched using, ED or hospital reports during a period of time, and we also collected those. And we also looked at when they were seen and whether they were in that period of time. So that's how we made the, the report that we needed to do. What we did find was interesting, like you said, there were actually 2 facilities that that most of our patients went to, so namely Queens and Straub. So they were all part of Epic, and
Right.
I think in the future we might do a similar type of thing, PDSA and how we at least track those kinds of patients.
Yes.
The other thing that I just learned today was the fact that you can get alerts as far as ED and patients on Epic, which I was not aware of. So that's another thing
Good.
we'll probably do in the future.
Yes. And, continue to evolve that process. There's the notification process, which is the time element. We all want to make sure that for the Medicare fee-for-service patient, you are able to bill, transition care management. That is optional. I mean, that's an option for you, and it's a revenue stream for you, especially if you're doing the work. And so if you're doing the work, like Dr. Kohatsu's wife said, why shouldn't we get paid for it? Let's do it. And so that's definitely one area. And then, the second area is the tracking piece. And so even though it's all part of the process, I kind of separate them between, the timing element for the notification follow-up and then the tracking piece. So you might be really good on the timing piece, but it's the tracking piece that you want to do a PDSA on. So really kind of segregate the area that you really want to focus on. If you think your tracking and your is great, then I wouldn't spend time on that area. Maybe it's the follow-up area that you'd want to focus on. But what I'd like to kind of leave you with is, just what are the things that stood out to you? We talked about that. Things that you could relate to. We are all part of the CPC Plus community. Hawaii is kind of a small place. We all kind of know each other. My cousin is your cousin's wife's uncle. So, we're all kind of, connected in that way. But feel free to reach out to each other. There is CPC Plus Connect. You can reach out to a specific person, or you can, pose a question out there on the Hawaii Regional Network folder. You can reach out to each other. We really want to make sure that we are becoming one big CPC Plus network community here in Hawaii. Just kind of a ready, set, go questions to think about. Where are you in the process of care coordination with hospitals, EDs, and urgent care? Do you need to assess the effectiveness of your current workflows or even your protocols? What protocols do you have in place for tracking episodic care management? And I think as we do this little pilot project here with the HHIE and Dr. Kohatsu, if anyone else is interested in doing that pilot project with us, please let me know. You can see me after this session, or you can send me an email. But if you want to be part of this, we're really looking to find solution-oriented ways to cut down on the hybrid process that currently exists. If you think about it, when you have a hybrid process, it makes things a little bit more complicated, but we're forced to do that right now because there's not a one-stop kind of 7-Eleven solution. It's a little bit, compartmentalized. And so as we work towards those single type of solutions of how can you get your information, or even limiting them to 2 different sources, I think that becomes a little bit more manageable. What are you using to measure and determine the effectiveness of your process? That's not always a question that we ask ourselves. We kind of implement the change and then we go, okay, next project. And I think evaluating the effectiveness of the change, that takes time, right? So we want to see how that plays out over time and to make adjustments as are deemed necessary. Care coordination tools. This is all out on the slide deck if you are looking for more information. Like if you are looking at the coding for TCM, that's a really good source right there on the bottom. If you're going, ooh, what are the codes for TCM? What are the requirements? That's a good source down there at the bottom. And then, of course, not that I'm here to plug CPC Plus Connect, but it is really a powerful tool, and it's something that you can use when it's convenient for you. And so this is our Hawaii Regional Practice Network. I do post a lot of things on here. I'm not the only one who can post things on here. You guys can share with each other. We're all out there kind of trying to do our best. And so the more that we can share and learn off each other, the better we all become. And so I leave you with that. I want to say thank you again to our panelists for taking the time to share with us. It's been very valuable. I thank all of you for your comments, your questions, and for sharing as well. And I think as we move forward, we'll be sharing some of the successes and barriers and challenges in this little pilot project with all of you, and we look forward to seeing where that goes. And so this concludes our session for transition care management. We are going to take a 15-minute break, and our last session will be on integrating behavioral health. And so we look forward to seeing you back in about 15 minutes. Thank you.
Just a quick note, the phone number there is not the right phone number. But if you need, I will be glad to like share my business card with you.
I'll correct it. Oh, sorry. I'll correct it and send it out. Okay. Oh, perfect. Great. Thank you.
Hello? Okay, great.
Oh yeah, it should be in the 508 version. And if not, I have my computer. Oh my goodness gracious. Just want to take these home and put them in my house. Yeah, we both had no. So in my section we had. Yeah. Oh, oh yes. Mhm. Yes. Yes. Perfect. Okay. 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 Now, do you want to put that up here? Yeah, maybe I'll just start with it up there. Yeah. And then do you want me to move your slides too? Because
Yeah,
you're
we
going to
can do
have to
that.
move that one because it's not connected to this
Yeah.
one.
And
Okay.
is that okay if I leave the microphone and speak from that?
Yes. Yes.
Okay.
You want to speak here, yeah? Yeah. So I like standing better. Yeah. Okay. Or they don't need to see me. You can hear me. Okay. Should I put this up here? Yeah. Okay. All right, everyone. We are going to get started. Thank you for hanging in there with us all day today. I hope you have had a chance to network with the people who had done a PFAC, network with people who are doing pre-visit planning and transitions of care. We're going to move into our last session, and this is on integrating behavioral health. And so this is one of the topics that as we look through CPC Plus, this is going to be an interesting topic here in Hawaii with just our dynamics. We are trying different things here because, you know, we're such innovative people in Hawaii. And so what I've done is we have a guest speaker that is remoting in from Baltimore. So I'm going to introduce her. Her name is Wendy Bradley, and she is the Knowledge Management and Spread Coordinator for the CPC Plus Regional Learning Network. She's currently the Director of Behavioral Health Integration at TMF Health Quality Institute. And many of you, if you've been attending those integrated behavioral health webinars, she's been a speaker at many of the webinars. Wendy has over 13 years of experience in primary care transformation, much of which has been in the implementation and oversight of behavioral health integration, team-based care, management of high-risk patients, and community engagement approaches to addressing determinants of health. She also serves as a faculty member for the Institute of Healthcare Improvement and has supported practices across the United States and Europe as they shift towards a whole person, whole team approach to healthcare. And so she's going to be speaking in this session. And we were very fortunate to also have Dr. Haunani Yao from Maui Medical Group. And so she will be here as well. She's on stage with me. And so they're going to kind of co-facilitate this session. And so just to give you some background on Dr. Yao, she graduated from the Hawaii School for Professional Psychology at Argosy University in 2009 and completed her postdoctoral training with the Eola Lahui, a psychology program focused on promoting the integrated behavioral health model in a rural health setting with a special emphasis on model of care for diverse and marginalized populations. Dr. Ayala's postdoctorate site placement was at Community Clinic of Maui, where she was tasked with developing the integrated behavioral health model. She was subsequently hired as a licensed clinical psychologist and was promoted to Integrated Health Director in 2012. Dr. Ayala recently joined the Maui Medical Group as their CPC Plus Medical Director and Behavioral Health Provider. Her role is to oversee the development of the CPC Plus practice transformation and to develop the behavioral health integration model. Dr. Ayala is passionate about promoting and empowering her patients to achieve health and wellness. And so we have those two speakers here today to talk about integrating behavioral health. And so without further ado, I'm just going to pick up the cell phone, which is how Wendy Bradley is going to know it's her turn to talk. So if you just give me a second.
All right. Can everyone hear me? I think that this is one of the biggest PDSAs ever, that we will be doing this remote for an in-person learning session. So I am actually in Boston tonight. I live in Nashville, and it's 9 o'clock right now. So I know it's only like, I think it's 3 o'clock there. So I'm very excited to be with you. And I also graduated from the University of Hawaii. So I love Hawaii, and I wish I could be there right now. Slide 2, please. We are going to be talking about the 2 options for Track 2 practices. We also know probably over the next year, Track 1 practices will need to start thinking about behavioral health integration. So this topic is really relevant for both tracks. And I will be going over the 2 options in a little more detail, and then Dr. Ayala is going to give you an example from how it worked in her clinic, and give you some more tactics around implementation. So slide 3, and thank you, Christine, already for introducing us, and we'll move to slide 4. So I have a question, and I cannot see the audience, so Christine's going to help me with this. So if you can, raise your hand if you currently have a co-located behaviorist in your practice. So Christine, 2 people. Okay, great. How many have a care manager trained in behavioral health that's doing some of this work? Okay. And does anyone have a care compact with a behaviorist for a referral compact to be able to refer your patients to behavioral health? Okay. And how many of you are in the early phases of planning on how to best integrate behavioral health? Okay, well, we know where we're starting. All right. All right, so slide 5. So behavioral health integration sits in function 3 in comprehensiveness and coordination. And so you will see integrate behavioral health services to support patients' common and complex behavioral health needs. And we know that this is important, particularly for higher risk populations. Really all populations have behavioral health needs, but the idea is to really have that be a part of primary care, because we know that 50% of visits that come into primary care have an aspect of behavioral health in them. So it just makes sense to have that service inside of primary care. Slide 6. So when we talk about behavioral health, there's a couple things I want to point out in this slide. First is the word behavior health. We use the term behavior health because it's all inclusive. It's not just mental health, but it also includes substance abuse, social needs, psychosocial stressors, and chronic conditions that have a lifestyle change element. We know so much of what we see in primary care now has to do with chronic health conditions and lifestyle change. So thinking about behavior health is behavior change. The other things I want to point out in this is it's team-based. So the behavioral health person is part of the primary care team, supporting the team in managing a panel of patients. It's also systematic, so it's built into the day-to-day workflows. It's not something separate on the side. And it's patient-centered, and we hear this term a lot, and the term patient-centered, when I think about it, means that we're really taking into account patients' beliefs, their culture, their value, and what matters to them in health, and that really helps drive the plan of care. So that's kind of the basic elements or the definition of behavior health. Slide 7. Now, before I get to this slide, I'm going to throw out a few questions that Christine's going to help me with again. I was actually reading a study not too long ago and looking at the top 9 chronic health conditions in the U.S. And the study illustrated what the prevalence of depression and anxiety was for each of those conditions and how often it was missed. So I'm going to throw a few of them out there and see where you all land. So think about diabetes. How much of the time do you think that there may be a diagnosis of depression and anxiety? Say a percentage. What percentage do you think of diabetics have anxiety and depression? And Christine's there and she can hear your answer. Okay. Okay. And it sounds like you're all right in that range. It's between 40 and 80%. The studies vary around that for diabetes. Now let's take chronic pain. What percentage of folks with chronic pain do you feel have a depression or anxiety diagnosis? We'll do the same thing, Christine. Well, you're all very close. Studies show between 80% and 100%. And when we look at hypertension, asthma, COPD, the stats are very similar, somewhere between 40 to 60%. Now, how often do you think the diagnosis is missed? We'll do the same thing, Christine. Yes. So it is missed 85 to 90% of the time. So we know that there's high prevalence, but the diagnosis is missed. Now, last question. With someone that has a comorbid depression or anxiety, does anybody have an idea of how much more it costs in total cost of care per month? Okay. $50 more a month. Anybody for $50? Sounds like we're doing a $50? Yeah. 100. All right, 200. Okay, we got a few at 200. Okay, 300. Anybody? A few at 300. 400. A few at 400. 500? Yes, a few at 500. Okay. So what we know on average for someone with a comorbid mental health condition, it's an extra $300 a month to provide care. So now we know that it often occurs with folks with chronic health conditions. We often missed it, and it costs almost $300 per month more on average. The other cost of not treating or managing behavioral health issues is time. So if you go ahead and look at the time, the slide, average around 5 minutes on a 15-minute visit, for an existing or new patient visit for someone with a behavioral health issue. For how many of you is that true? When there's a behavioral health issue, you find yourself spending more time in the room. Is that true? Yes. Okay. So slide 8, go ahead and let's move to slide 8. So the benefits of behavioral health integration. When I started in behavioral health integration at South Central Foundation in Alaska around 2004, there was not a lot of data on this, but we knew that when we started to have relationships with our patients, we knew that there was more going on there than just the medical piece. And our patients didn't want to be sent here or there or to different places. They wanted to get all of their care in one place. And so we started integrating behavioral health into our primary care clinics. And what the studies have shown since then over the last 20 years or so is that there is a proven significant benefit for depression and anxiety with collaborative care. That we know that interventions work in a variety of settings. So they can work in the exam room, they can work in a room down the hallway, they can work in an ER or an urgent care setting or specialty setting, pediatrics, with a wide variety of conditions. And this is kind of a duh study, but when treated simultaneously with mental health, chronic health improves significantly. Again, if we think about chronic health conditions, many are improved by lifestyle change, which is behavioral change. So slide 9. So the assumptions, the underlying assumptions for behavioral health integration is that it's a whole person approach to care, which means we're looking at all the aspects of a person's life that might be impacting what they're doing or not doing. And to illustrate this, there was a study out maybe as I was talking to someone about a month ago. They were actually collecting their data, and they looked at readmissions, and they looked at a care manager, and had them review the chart and talk to the patient. And it was a diabetic that had a readmission. And an RN, who was the care manager, reviewed the chart and said, well, the reason why they were readmitted is they weren't taking their insulin. When there was a social worker that was the care manager that looked at the chart and interviewed the patient, she said the reason why they were readmitted is they didn't have transportation to get their insulin, nor did they have money to pay for their electric bill, and so they couldn't keep their insulin cold. When they had the behavioral health person look at the chart and interview the patient, she said, well, the reason why there was a readmission is that patient has depression and they don't have the energy to take care of their diabetes. They just don't care. And so the reality is that if we're neglecting any of those things, we're providing incomplete care. So the assumption for integrated behavioral health, again, is that we're looking at the whole person and what are the aspects or the barriers or the core issues that are driving that condition. The next piece is it's team-based. So that behaviorist or that care manager is working closely with the team to provide care. That no one person is responsible or for that outcome and doing all the work themselves. They're working together, and it's population-based. And I think what's really interesting when we start to look at integrated behavioral health is we can start to move towards prevention, which is really important or kind of new in behavioral health, particularly when we look at trauma or childhood trauma. If we're able to do intervention at preconception to age 3 and create and support families, we can have a profound impact at chronic health conditions later on. I'm sure many of you are familiar with the ACEs study, and that there is a stepwise increase in the number of adverse childhood events and the prevalency of chronic health conditions. So there is a prevention piece or a population health piece, and that's where also screeners come in and being able to identify those underlying mental health conditions that might be impacting chronic health conditions. It also becomes a routine part of healthcare. Asking someone about their drinking habits, what they're drinking and how often is just routine. Asking how they're feeling becomes routine. That it's not something to be ashamed of or that there's a stigma around. That having stress and feeling depressed sometimes is kind of normal. In behavioral health, we like to say that depression is a cold and anxiety is the flu. It's very common. And so we want patients to feel that this is a routine part of their health care. And that everyone on the team becomes more educated and familiar with underlying behavioral health concepts like motivational interviewing, or also identifying potential behavioral health issues like sleep disturbance. We know that depression in many ways is a sleep disorder. So if someone's coming in with sleep issues, it triggers us to want to know more, do some further assessment, maybe getting intervention in earlier. So the whole team gets a little bit better at looking at the whole person and what are underlying or core causes. Slide 10. So with that being said, we are going to talk about the two options. I'm sure many of you have read the 2-page summary of these. And the first one is care management for mental illness. And the other one is primary care behaviorist model. Both of these are evidence-based and have a lot of good research behind them. And essentially, if we were to break down the difference, the care management for mental illness approach is basically a care manager that is using a protocol-driven approach to manage depression. The integrated behaviorist model, on the other hand, is a credentialed provider that's able to treat a wide range of mental health and behavioral health conditions in primary care. So in a nutshell, that's the difference. And we're going to... We're going to get into the details of those, so I won't stop there. Okay. Slide 11. So looking at the first option, care management for mental illness and the essential elements of that, what are the core elements of this model? The first one is that you've identified one or more prevalent mental health conditions to be managed. And you would do this by looking at your population. What's showing up a lot? What's a high frequency condition? What's keeping you in your office late? Many people start with depression, and they start with the PHQ screening because that's a measure that they're starting, that many people are beginning to be measured on. So they may start with depression, and then there's a treatment algorithm. And so what that means is that when there's a positive PHQ, let's say a PHQ score of 10, there's a treatment algorithm. So if it's a 10, potentially maybe there's just a conversation and a brief action plan around increasing activity and stress reduction. And then if it's maybe a score of 15, maybe there's a referral out to a credentialed behavioral health provider. And if it's a score of 27 and there's suicidality, maybe there's some crisis intervention, and then a handoff to a clinician for crisis intervention that's being coordinated. And then there's treatment monitoring using a validated instrument. So think about the PHQ. So not only are you screening, but that case man or care manager is also tracking the progress of the treatment. So they would be screened, and then maybe they were started on meds, and then a month later, they were re-screened again to see if the score goes down. And so they would continue to be screened until that depression's in remission. And then the care manager has training in behavioral health conditions and has the ability to facilitate higher level care. So if someone is suicidal, they're able to coordinate maybe a handoff to an inpatient facility. And coordinate that. Typically, continuing care management for 16 weeks or longer, and there's often decision support from a psychiatrist. So either the psychiatrist is providing clinical supervision to the care manager and overseeing sort of their caseload, or there's actual consultation with the team, regular consultation with the team, or the provider is able to call the psychiatrist for a consultation. But those are the essential elements of care management for mental illness. So that this is option 1. Slide 12, we're going to take a look at what the care manager does in this role. And one of the things you might be wondering right now is can this be the same care manager that's doing my longitudinal care management? And yes, it can be, but they have to have the specialized training in behavioral health. So slide 12 shows us particularly what this role does. So they do the screening, treatment monitoring, and health coaching. So let's just keep going with the PHQ. They're screening, they're monitoring using the PHQ and providing that health coaching. They're also doing the referral. So let's say someone has complex PTSD. They're doing the referral out, coordinating of the BH and social and medical pieces together. They're maybe working with a psychiatrist that's treating them and making sure that that information or the documentation and treatment recommendations are getting back to the provider. They're providing support in crisis situations. And this is also key, that they're doing proactive panel management and tracking. So that patient with depression is going into a depression registry where they're being tracked and monitored And so if someone doesn't follow through on a referral, they're doing outreach to that person. And so they're keeping track of all those positive depressions. And again, this may work with whatever condition you choose. So it could be dementia if you're working with a geriatric population, or maybe an audit if you have high prevalency of substance abuse. Next slide, slide 13. So the skills and background for this person who typically fills this role, it could be a bachelor's or master's level behavioral health practitioner. Now, I have seen in other regions where they actually hire someone with a behavioral health background to be their care manager for the team. And then they just work closely with the MA, because so much of care management is organization and coordinating care. And particularly for this, they already have the training in motivational interviewing, already have the training in psychopathology. They can do basic screening and tracking of conditions. So you can, so there's a wide range of social work or psychology professionals that could do this work. Or you can also have an RN do this work. So maybe your existing care manager that's getting extra training to be able to do this, or a health coach. And again, the main elements are motivational interviewing, understanding or aware of all the social services in the area, and basic care management. The skills, I've already talked about motivational interviewing. One I want to call out is the instilling hope. That's such a big part of what we do in primary care. And so much of the time, I can tell you in primary care, folks just want to know that they're normal and that this can get better. And a big part of our job is to listen and provide that hope, or help them see hope for the future. And we often do that by using strength-based interventions. So figuring out what someone does well, where else have they been successful, and that how they can apply that to what they're trying to work on now. They're using self-management support. They've got BH clinical knowledge. Communication is huge because they're really part of that team, informing the provider about where the treatment is with the patient, and engaging families and caregivers. Any questions so far? I'm going to move to an example workflow. I think it will also help walk this through, but any questions before I do that?
No, Wendy, no questions.
Okay, slide 14. So if we take an example of a 58-year-old grandmother with a 15-year history of type 2 diabetes and hypertension that struggles with weight control and insomnia and headaches, she's coming into the clinic. Let's just say she's a brand new patient, and she's screened for depression by the MA and scores a 15. And remember, this is option 1. And in this option, the PCP may notify or send an alert to the BH care manager for follow-up. That BH care manager follows up by telephone. She could also jump into the room if she has the availability, but she could follow up with that patient by phone, having a conversation about that positive PHQ, and reveals a history of depression and high stress due to caring for her sick husband. And she's working full-time. That BH care manager discusses self-care techniques with the patient, and then puts the patient in the registry for tracking. Over a couple of visits, she realizes that she needs some extra support, and actually does a referral to a co-located master's level therapist who's in clinic 2 half days a week. Now, in other clinics where they might not have that co-located therapist, they may do a referral out. Maybe they have a care compact with another organization. The co-located MLT, master's level therapist, and BH care manager coordinate with the psychiatrist for a med adjustment. And so over the next 6 months, she has 2 check-ins with the BH care manager, 8 follow-up therapy visits, and gets her blood pressure taken at the same time and has 1 visit with a psychiatrist. So over that period of time, she improves greatly. Her BP falls and her hemoglobin A1C is at 6.3. So you can kind of see the workflow of how this would work with option 1. So with that, if you don't have any questions, we'll go ahead and move to option 2 and walk through that one. So slide 28. Okay. So this is the primary care behaviorist model. And the key elements for this is it's a credentialed behaviorist that actually is part of the primary care team. And the clinics that I was in, they actually sat with the primary care provider. And when I say credentialed, y'all might be familiar with the alphabet soup of behavioral health, but there's actually many different credentialed behavioral health providers that could fit into this role. The ones that are most prominent are the LCSW, an LPC, which is a licensed professional counselor, a marriage and family therapist, a psychologist, or a PsyD. I've also seen BHNPs, nurse practitioners or psychiatric nurse practitioners also fill this role. And they sit again with the team, often seeing patients right in the exam room. There are same-day warm handoffs for behavioral health and chronic health conditions. So how this might look in primary care is in my clinic, I would wear a pager. In other clinics we actually did instant messaging. The provider would instant message from the room and say, hey, Wendy, I have a patient in room 3. Are you available? I would usually give my ETA, I can be there in 5 minutes. I would go to the room. The provider would come out and say, hey, I'm really concerned about Mary. She's showing early signs of dementia. Can you do an assessment? The provider would introduce me. He would say, this is Wendy. She's part of the primary care team. She specializes in things like memory. She's going to spend a few minutes with you. And then we're going to talk about some next steps. So then I would sit down with Mary, explain my role in the clinic, and I would maybe do a mini cog with her. This could be any condition. I'm using dementia as an example. Right after that, I would come out, have a conversation with the provider about what I saw, what the intervention was, and what the plan was. I would document right in the health record, and then work on what the plan would be for Mary or next steps for Mary. So there's a same day connection. And you can see I'm working as part of the team. And the provider, my primary role in many ways is supporting the primary care team. We're co-managing the panel of patients. I don't keep my own patients and the provider has their own patients. We're working on it together. I'm able to facilitate to a higher level of care. So in primary care, typically about 80% of what you see is able to stay in primary care. So I'm able to treat most of the mental health conditions or behavioral health conditions that come into primary care. Only about 20% of the time there's a referral. As you shift to team-based care, what you'll see is your referrals go down. Because you're able to do a lot more in primary care as you have a primary care team. And then there's a methods for engaging patients. So in the clinics I've been in, there's typically 3 buckets or ways to identify patients that need behavioral health services. The first one is the obvious one, a screener. So PHQ, an audit, and ages and stages for children, maybe an adolescent screener. If one of those is positive, they would bring me in. The next one might be a data-driven trigger. So let's say in the clinics I've been in, there was always high rates of chronic pain. So anyone that was on an opiate medication had a consult with a behavioral health provider. Anyone that was 80 and over, we started to do screening for dementia. So there might be triggers based on the needs in your population that you decide, or anyone with an A1C over 10, that you decide actually is at higher risk and could use an assessment and a preventative look at with a behavioral health consultant. The other one is if the provider senses that there's something that needs to be done, or any other person on the team. I even would have a MA come in and get me and say, hey, I think this person really needs to talk to you. So those are typically practices have ways to trigger a behavioral health person to come into the room. And then a brief intervention or brief therapy. So the difference between integrated BH and maybe traditional therapy is in traditional therapy, we're looking at what brings someone maybe to this place, and it's a deep dive into some of those root causes. In behavioral health integration, I am looking at what's the presenting issue and how I can support someone in moving forward. So I'm teaching them skills that they can practice today. So if someone's got panic disorder, I'm teaching them how to manage that, what the anatomy of a panic attack looks like, and what are the skills that they can use. And I could maybe follow up with them by phone in 2 days to see how that skill is working, and then adjust it if needed. So they're not 50-minute sessions. It's very flexible in the way I'm working with someone. The other thing that's unique is my relationship is longitudinal, just like it is with the primary care team. So I might see Mary today because she's stressed about her husband's illness. I might see her next year for anxiety about a grandchild. I might see her the year after that when there's a death in the family, let's say. So I'm seeing Mary over the course of her life as well. Maybe I'm helping her with her diabetes, but I'm working with her through lots of different conditions and times in her life, just like the rest of the team. And so on slide 29, you can really see the difference between traditional therapy and integrated behaviorist work. And with the goal, thinking about this, is that we are providing access at the time that it's actually needed, when the person is most motivated to make a change, because I'm able to see them when they need to be seen, and I'm able to do that over the phone, and it's flexible, and I'm there to support the team in making sure that they have what they need when they need it. And so you can see the difference between these two. In traditional, if you're lucky, they're located in the same building or on the same campus, but oftentimes they're across town. In an integrated model, it's in the same office. Patients are often seen in the exam room, and the beauty of this, if my provider calls me to go into the exam room, they are able to move on and see their next patient. So it really helps with the efficiency of the workflow. So they're no longer having to spend that extra time. They're able to hand it off to me when they go in and see their next patient. I'm charting in the same chart. I have open access, just like my provider team does. My visits are 20 to 30 minutes. I have brief documentation. I'm not doing long treatment plans and process notes. I am doing a basic SOAP note. I'm focused on functional outcomes. My goal is to help someone improve their functioning over a wide range of conditions in a way that actually works in their life. There's a shared treatment plan or care plan. So everyone on the team can see what the plan of care is, and my work is integrated into that, and I'm able to see what everyone else is doing on the team. So when that patient comes in to see me, they're coming into the same office they're familiar with, and it could be that we do take their blood pressure when they're in the office because they're already there, and I know, seeing the care plan, that this needs to happen every time they come in. So we're able, again, to work together, and communication and feedback are immediate. So my provider knows immediately what underlying factors might impact the care outcomes. They understand the other elements of that and can incorporate it into their treatment. Slide 30. So what the behaviorist does is acute behavior health. So remember, they're credentialed, so they're able to diagnose and treat. So anytime there's a psychosis or acute distress or suicidality, that BH can come in immediately and do that assessment and triage. They're also providing screening, but probably a wide range of screening and assessment, from dementia, chronic pain. We also used to do positive pregnancy tests. We had a very high-risk population, and so we actually did a screening with anyone that had a positive pregnancy test, making sure that they were safe, if there was any history of substance abuse, anxiety, depression, so we could get treatment in early. We found that if we waited till the month 3 for their OB visit, we really missed that opportunity. So they're providing a wide range or broad range of behavioral health needs. I remember even doing brief couples counseling in clinic. You jump in just like the rest of the team does to resolve and support families. You're doing motivational and lifestyle change for chronic medical conditions. And in our population, there were high rates of rheumatoid arthritis, fibromyalgia, irritable bowel syndrome, somatic symptom disorders. We know in high-risk populations that about 30% of visits have an element of somatic symptom disorder, which is really hard to treat because the distress of the condition outweighs what the provider's seeing. So being able to support the team and provide consultation on how to manage that. And social service support, so housing, employment, community resources, again, looking at that holistic approach to care. Slide 31. So the behavior skills and background, when I've hired for this condition, and I know University of Hawaii has a fantastic social work department and counseling department. I know that there's some other universities there as well that have really good training and resources. But what I found, regardless of the credential or the background, we typically hired for personality. Most behaviorists, I found, if they're really, really good at therapy, they really struggle sometimes working in primary care. They're spending way too long in the room and really want to take that deep dive. So I would typically hire for someone that was comfortable seeing what was ever in front of them, being able to make a decision, could provide concise, brief feedback to the team, and was strong diagnostically, because you're also consulting with the team. So the provider's coming and you're providing insight or information around a condition. They're very open to new ideas, not really stuck in their old way of doing things. I've actually kind of found the sweet spot is about 2 years out of school. There's a tolerance for uncertainty. The other thing I found in primary care, you need to be able to kind of see what's in front of you and support the team in that. So within a year of hire, we also had them get substance abuse training so that they're able to help with that. One thing I also found that really helped was actually having the whole team interview the behaviorist, because if the team chose that person to work with, there was a camaraderie and a good working relationship from the beginning, and they were much more likely able to use the behaviorist. So I've kind of gone over option 1 and option 2. Are there any questions right now?
Yes, there are questions. The mic runners. Can you hear me, Wendy?
Yes.
Okay.
This is Dan Belcher, internal medicine, single provider. What's going to be option 3? Because neither one of these are really going to be practical for a single doctor's office in a rural area where we don't have these people, and the amount of money you give us really doesn't allow us to hire them. Neither one of these are going to be an option that I think I can do in my office. And I can see by the answers we had, almost nobody is doing any of this yet so far, except for maybe people that have a multi-provider clinic. So this is just unreasonable and ridiculous.
So Wendy, did you hear that?
No, I couldn't hear it. I'm sorry.
So I'm going to summarize the question. They want to know what is option 3, because if you're a sole practice, option 1 and option 2 aren't really viable.
Okay. So, so if you're a solo practitioner, do you have a care manager in your clinic?
No.
So who's doing the care management? Is it the provider right now?
Through the provider and through the physician organization.
Doing the care management.
Yes.
So what I found, at least in a lot of the solo practices in other places, whoever is doing that care manager, they're starting with that and training them in basic behavior health protocols, and starting with just depression. So starting really, really simple. So starting to screen using the PHQ-2 or the 9 if it's positive. And then they would go into a depression registry and they're doing that self-management support. That's where I've seen a lot of solo practitioners start with, or build a relationship with a community behavior health clinician. I know in one of the FQHCs that we had, we actually provided space for a behaviorist to just work in, and we provided free rent as long as they gave us access. I actually have a slide on some ideas for solo and solo practitioners in this work. But those 2 options I've seen work pretty well. But starting small.
Okay, they were nodding their head yes.
Okay.
Any other questions? Okay, no other questions.
The other thing I would say is, really quick, is that I think there's time to do this. I don't think this has to be done tomorrow. And just think about starting small. Maybe your very first step is just looking at where the pain points are and where you might need more help with. And if you go with option 1 and have that care manager, what's one thing that they can learn under a specific protocol? And that's, if that would be interesting for you all, we could do another session just on what a depression protocol looks like.
Are you guys interested in that? Maybe doing a follow-up session on what a protocol for that would look like? Yes. Yes, we might.
Okay, for care manager. So again, so we'll start small, and we'll slowly get there. So not all done tomorrow. But with that, I want to make sure Dr. Ayao has enough time to give you an example. She's done this in Hawaii and has some really good insights on how this works in Hawaii. And so with that, I will hand it over to her, and she's going to give you that example. I think for option 2, it's going to be the integrated behaviorist. So, Dr. Ayao.
after hearing the comment, I'm just wondering how many of you are actually going to choose the behavioral health integration option of the two? Is anybody? Or okay. So at least my talk is sort of geared towards you then. Because that's what I'm going to be speaking about, is the behavioral health integration model. Wow, I'm kind of short, aren't I? Okay. Interestingly enough, I'm mainly going to be talking about my experience at my prior place of employment, which was an FQHC. But I recently came to work at my current employer, Maui Medical Group, and they actually, we entered into conversations thinking that I was going to be part of a collaborative care agreement, and I would be setting up a private practice. And over time, in speaking with me, they really saw the added value that having a credentialed behavioral health provider on site brought to the table, and so here I am today. My current practice is actually much larger than where I came from. So I'm really kind of adapting what I've learned in my smaller practice at an FQHC, which really wasn't that small, but compared to where I am, we have 30,000 patients, 48 practitioners, and 5 clinics. So I came from a place where there was much less providers, and I'll go over that. But just a little bit about FQHCs, because this is where, that's where I came from, and that's what I'm going to be speaking about. So FQHCs, if any of you don't know, are federally qualified health centers, and they serve the underserved. Yeah, I know. That's better. Okay, yeah. Yeah, okay. Okay. All right, that's better. FQHCs have been practicing this model for a while. I think they're really primed for it because FQHCs are set up to be a one-stop shop. FQHCs also receive special monies and grants to be able to enable these services. And then, as you can see, we had a pretty diverse patient population. And we served mainly Medicare and Medicaid and uninsured. How do I get back to that? My next slide. Oh, okay. Having some technical difficulties. Well, I am. So this is just kind of a picture of what our staff look like. So as you can see, we had a pretty strong behavioral health staff, and that was in part because some of these staff were grant funded. However, a lot of these staff members are also sustainable. So if you have a licensed practitioner, so we had myself, who was the integrated health director. We had another full-time psychologist. We had a substance use disorders counselor, a tobacco treatment specialist, a registered dietitian, and then our behavioral health care coordinator, who is really kind of the linchpin of our services. We had a variety of physicians. So we had pediatrics, OBGYN, family practice doctors, two nurse practitioners, and internal medicine. And we had a rather large nursing staff, as well as front desk staff and health information technology, or we also refer to them as medical record staff. And so just a little bit about our model. So for us, we really, we developed a model to meet our needs. And so we developed a hybrid model. And so Wendy really spoke about having the primary care behaviorist model, but we did develop and implement that model, but we also did provide traditional mental health or longer-term mental health care. And we did that for a couple of reasons. And the first one is because there's a paucity of mental health services on Maui. And the second one is I spoke about our patient population, and really kind of struggling with a lot of the social determinants of health. So we had high rates of patients with comorbid PTSD and chronic health conditions, and our physicians really desired to treat these patients as a team with us so that they could get the support and the insight from the behavioral health providers. And then just one more thing about, we really wanted to promote increased access. And so there was a number of different pathways for patients to get to us. And we did both the warm handoffs. I don't know if you all know what warm handoffs are, but that's basically that identification and introduction and same-day visit. And then we also did registries or data mining as a way that we could, it was kind of a checks and balances for us. And if for some reason that particular day warm handoffs were less, it was a way to generate productivity. And these visits are billable, well, if you meet the time requirements. So how did we set up our schedule? So there's two, as I understand it, one way that they have their behavioral health providers set up their schedule is it's kind of staggered with 30-minute warm handoff, 30-minute follow-up or intake, 30 minutes. So it follows that 30-minute pattern. And the reason why they stagger it that way is so that there can be increased access. But for us, we found that it was best for us to devote entire days, either to scheduled appointments, and then entire days to doing the primary pace, primary care behaviorist model. And together with myself and the other psychologists, we provided 4 out of 5 days primary care behaviorist coverage to our physicians. One more thing I want to talk about, if I just go back. So again, it was pretty open access scheduling, but when it came to our primary care behaviorist days, we really found that it was important to protect that time. Otherwise, I think that people are really used to the traditional referral model and are just wanting to put scheduled patients instead of having that open access same-day visit for patients. So that was something that we learned because we were quick to put a follow-up if there was no room for follow-ups. And I think Wendy spoke about workflows and processes, but over time, this is what this ended up looking like for us. So we targeted depression, anxiety, pediatric obesity, and uncontrolled diabetes. And so Wendy spoke about how people who are trained in this model really have specialized training in conceptualizing the patients from the biopsychosocial approach. So not just the psychosocial components of a disease, but also the biological components of disease. And we also targeted tobacco use and substance use. And so the way that these patients, we identified these patients, the first one, all new patients filled out basically an HPI, and any of the positive behavioral health screen answers went to our care coordinator, who, depending on who was available, would either do a warm handoff or what we referred to as an anticipated warm handoff because it was a prior identification, or she conducted outreach. And then we also used the depression and the PHQ-2 and the GAD-2, which are 2 brief anxiety and depression screens. And so from those, they automatically generated a warm handoff or an auto referral to a behavioral health provider. And then, of course, A1C of 9 or higher generated an auto referral or a warm handoff to a behavioral health provider and a dietitian. And we worked very closely with our dietitian. And then pediatrics, it was by diagnoses, and that generated an auto referral to a psychologist and a dietitian. So for us, this was the behavioral health care coordinator was really an essential position. She was the cornerstone for us. She was the main point of contact, essentially. So if for some reason one of us were not available, meaning myself or the other psychologist, or let's say even the tobacco treatment specialist got warm handoffs, she would go and stand in and briefly explain behavioral health services and then schedule an appointment or identify a future time that the patient was coming in for a primary care visit, that we could get in and see the patient on the same day. I think that's, so our program development process. So I don't know that I would call myself an expert, but I do have experience in this, and I heard another presenter talk about this. It's really a continuous process of improvement over time. And the other thing for us was buy-in was key. So each time there was a new provider who came on board, and at my current job, it's really spending the time explaining to the providers, you know, the benefits to them, the benefits to their patients, and really getting them excited about it. What else? And then just having a stable work environment is important. And then the other thing that was helpful for us is when we aligned our pay for performance efforts. So if there was one where we needed to be focusing on depression, and we could select an option, so we would select depression as well. And that helped us to stay consistent. So a little bit about how patients felt about it. Our patients really, really appreciated this model. And overall feedback was overwhelmingly positive. So our Native Hawaiian patients really expressed appreciation for kind of that extra time, and that we would take to understand, you know, a unique perspective, planning, education, and feeling understood. And our Marshallese patients really appreciated having the extra education and kind of that more personalized approach and hand-holding. So these are just some of the patient feedback comments that you can take a look at. So, you know, I love that you talk to my doctor, you help him understand me and my challenges, our relationship is better. A lot of patients really enjoyed having access to their services all in one place. They're thankful that they now, you know, so it's extra time that we get to spend educating patients. And Christine spoke with me and wanted me to kind of maybe put forth some hypotheses about why this was a fit for patients, and I guess in Hawaii, but I just was speaking in terms of why I believe it was a fit for our patients. So these are a couple of common complaints that I've heard from patients about primary care. So kind of feeling like a number in the mill, I don't matter, and so the primary care behaviorist health model, well-functioning and harmonious team can really give the feel of a caring family. And then the other one is waiting 2 hours to see my doctor and talking with her for 5 minutes. That was a common complaint in our health center. And so a behaviorist can really be seen as an extension of primary care because we are a member of the primary care team. And so that helped to generalize to their beliefs about their care at our health center. Our providers really, really appreciated this model. And on my last day at the clinic, that just provider after provider kind of coming up and saying, oh my gosh, I don't know what I would have done without you and taking care of some of these complex patients, just knowing that you were there to support me and kind of even just listen. That's some of the part is the support that you give, and empathizing and education. And so the other part that our providers really expressed appreciation for was witnessing health outcomes with patients who'd been stuck, who had progressing. And like I mentioned, having an increased understanding about complex patients. So I actually thought about this a little bit, and I just wanted to spend a couple of moments and tell you about the steps that I took at my current job. So the very first step that we actually took is that I had my medical office assistant really take the time to develop a solid referral list. So of therapists and psychiatrists, and really understanding what the resources were in the community for patients, because we weren't gonna be treating all these patients. There were some patients who desired longer term care or needed specialty mental health care. And so kind of some steps you could take with that. You could see if there's any existing resource lists that you could use. You could also go on Psychology Today. If you type in your area code, it pulls up a whole list of therapists ranging in terms of background and experience, and it talks about their specialty as well as insurance is accepted, location. So that was the very first step we took. And then the next step we took was we conducted a needs assessment. And since I have so many providers I'm working with, we did it in a survey-based model. And so it was just understanding our physicians' attitudes towards behavioral health, working with a behavioral health provider, actually, let me say, and their experience in working with behavioral health providers, their comfort in working with behavioral health conditions, and the other important thing was their beliefs about their patients' treatment needs. Where were they spending the most time? Where did they feel like their patients were stuck? Where did they feel like their patients could benefit? And so overall for us, our providers had a positive experience. They mainly worked from a referral-based model in the past, and they believed that our patients needed assistance with depression, anxiety, and severe mental illness. Then the next thing we did is we took a look at all of our frequent flyer behavioral health conditions by diagnosis. So some patients might not have been identified. Who's utilizing your care the most? And for us, we were actually surprised. I don't think that we knew that. The number one condition was actually dementia. More than depression, more than any substance use disorder. I don't know if maybe dementia is being more accurately identified, but it was just more data that we could use. Then we looked at our EMR capabilities to see if there was, what screening tools was available. And for us, it was just the PHQ-9 and the Audit-C, which is an alcohol use screening tool. And then we looked at our pay-for-performance efforts, and then we chose depression. So we chose one condition to start with, and we developed a workflow, and the workflow involves right now just getting kind of a baseline and administering the PHQ-2 to every patient that's coming in, and the medical office assistant is doing that when they're working up the patient. And then if it's positive, so it's 2 questions about depression. And if either one of those are positive, then they go on to do the PHQ-9, and the provider goes into the room and briefly discusses it with the patient, and then discusses the behavioral health services at the clinic and the possibility of having a warm handoff to one of their colleagues. And if there is a referral, I think our cutoff was a PHQ-9 of 10 or more. But I think that's it. I think you really need, if you want to do this model, I think the behavioral health integration model, you really want to recruit the right people, because a lot of mental health providers are used to seeing one patient after another, and kind of, confidentiality is different when you're working from this model. You're really sharing patients, so really informing patients about that as well and being comfortable with that. I think that's all. Does anybody have any questions?
Any questions for Dr. Yao? Okay, I know that was a lot to take in, so thank you very much. We're just gonna thank you very much. Okay, so I am what is stopping you from going out of that door, sort of. But I did want to just kind of close. If you can submit your feedback survey, it is that bright orange paper in your folders. We'd really appreciate that. We love to hear feedback from you guys, how we can improve, what things you liked, what things you didn't like. I mean, we are going to be doing these learning sessions 4 times a year, 2 virtual, 2 in person. And so we want to make it worth your time. You know, like you guys have patient-centered focus, we have practice-centered focus. So I use a lot of just the concepts that we have in CPC Plus with you guys too. And you know, we want to make sure that this is beneficial for you and for your staff. We really appreciate that you spent the full day with us. James Lee will be here, and myself, if you guys want to connect with us. We really want you to make sure that you're connecting with each other as well. What is this? Oh, okay, we're going to be using your feedback reports to drive the learning content for session 3 and session 4. So I will be looking at the data that you guys submit. That's kind of how we gauge some of the topics. But if there is a need that you guys have that I may not see in the numbers, because sometimes it's difficult to see what the needs are, please reach out to me or reach out to your PO. And then you know, I want to just reemphasize, these are learning collaborations and sharing. And so this is not really us teaching you anything. It's really us sharing so that we can be more efficient in the process and in the transformation journey that lies ahead of us. This is a 5-year project. Or program, excuse me, and we are going to get to know each other very well. And so, again, I just thank you guys, and we'll be here after, but I definitely want to let you guys go unless anybody else has anything else they'd like to share. All right. Oh, yes, Elisha. Sorry, one more thing I might have forgotten.
I just want to put in a quick plug. I'm Alicia Jewett with the National Learning Team, and for those of you who have selected one of these behavioral health models or are interested in pursuing them, we do have action groups kicking off tomorrow. So the care management behavioral health model action group kicks off tomorrow, and the behavioral health PC model kicks off on Monday. So that's another opportunity for you guys to engage with one another and peers from across the nation as well.
All right. Thank you very much. Thank you for coming, and have a great rest of your week.